See, when you are watching AP, in AP view, you cannot see foramen ovale. For that, you have to first extend the neck. So that is we are telling submental. And now come little oblique. You can see the foramen ovale clearly. So again, AP, submental and oblique. Submental and oblique, we can see this. So in this way, we have to focus the foramen ovale. In the same way, if you see the whole skull with mandible, so this is AP view. Now coming submental and see the foramen ovale in between the mandible and maxilla. That is the only gap through the buccal mucosa. You can see the foramen ovale and enter through the foramen ovale. Showing again, see AP view. I am watching, that means who am I? I am the image intensifier. That's my eye. I cannot see it in AP view. I have to come to submental. Okay? Then oblique. We can see the foramen ovale. So we can see it's looking like oblique, but actually it is AP with the patient. So once we see the AP, now we come here. So what we are watching here, this is the mandible. This is the lower border of the occiput. Here is the maxilla. This is the anterior border of the ramus. Here you can see the notch, coronoid process, condylar process. Lateral border of the maxilla is the ramus of the mandible. So this is the AP view. In AP view, I cannot see the base of the skull. So I have to see submental view. For that, once we take the C-arm chordocephalic, so we will see the mandible is going up and the base of the occiput is going down. So that will create the submental view. So I will do it on video, and you will see how from this submental view will create a different picture.
Live chalo.
So we can see how the base of the occiput has come down and the mandible gone up. That's the submental view. Okay, mentis, so we can see the lower border of the mandible, the angle of the mandible, ramus of the mandible, lateral border of the maxilla. This is the ramus of the mandible. So this is the space in between the anterior border of the ramus of the mandible and the lateral surface of the lateral border of the maxilla. This is the space through which we can enter, we can reach to the base of the skull. So this is the submental view. Now to see the foramen, I have to take the C-arm either right oblique or left oblique as per my choice. So I will go to the right side. Let's see. Now I will do right side oblique.
Live.
I can see the very clear foramen ovale in between the lateral border of the maxilla and the ramus of the mandible. Now you come to know the first step AP, then chordocephalic, then oblique. In that way, in 3 steps, you are getting the foramen in between the mandible and maxilla. Then another step to see the maximum ovality of the foramen. Again, I will do cephalocaudal to see at which position I will get the maximum oval. So after getting the foramen ovale, I will again do cephalic and caudal so that I will see where the maximum ovality of the foramen ovale is getting. Because if you see foramen ovale is like this, if you are watching from here, you will get the maximum ovality. If you are watching from here, automatically the ovality will be less. If you are watching from here, you will see the less ovality. So in that way, you can compare at which position after getting the foramen I am getting the maximum oval foramen ovale, so that you will get the maximum space to enter into the foramen ovale. So I will show you by changing the position of the cephalopopliteal tilt. You can see now this in this position it is there. I will change the position and I will show you how the size of the ovality is changing with the changing of the cephalopopliteal tilt. Okay. I have made the CM more cephalocaudal. Okay. Now see what is the size of the shoot ones. Yeah, we can see what is the size of the foramen. Now I will transfer it on this side. Now I will change the angulation of the cephalocaudal. So now I will make it more caudal, caudocephalic, and we will see how the size of the ovality is changed. Okay, shoot. Now you see the size, and you see the size here. See here you see the size, and here you see the size. Now I will show you with the cephalocaudal tilt how the size of the foramen ovale is changing. See, size is becoming bigger. Now I am going opposite side. Size is becoming smaller. Okay. Off. So now after getting the perfect oval foramen and maximum ovality, now you will start the procedure. If you are thinking for V3, you have to go to the most lateral part of the foramen. If you are thinking for V2, you are in the middle of the foramen, and for V1, you will go to the most medial to the foramen. So for that, as usual, we will take the needle entry at 2 to 2.5 cm lateral, but you can little bit change the needle entry point. If you are taking for V1, you will take little lateral and you will go towards the V1, towards the most medial. If you are going for V3, you will take little more medial and go more lateral, and in between two, you will go for the V2. But the most important thing, when you are going through this buccal mucosa, there will be a chance to enter into the oral cavity. That's why what I used to do, I first take the entry point, then I take the needle little lateral to hit the ramus of the mandible, and after that I change the direction and reach my target. So you are avoiding the entering into the oral cavity. Then another point, because here this is a submental view, so I don't know the depth of the needle, so always better don't go inside the foramen. First you hit the outside the foramen. Outside means first you take the last bony point. Say for example you are going for V3, you will try to hit the most lateral part of the foramen and you hit there. And because we are using the bending needle, so if I am hitting the lateral border in such a way that I will just test I can enter into the foramen, at that position you go to the lateral view and you enter into the foramen, because you will be able to see the depth, because in different patients size of the face is different, the depth will be different. That's why without knowing the depth you should not enter into the foramen ovale. For V2 you try to touch the lower border and then you enter into the foramen in lateral view. For V1 you try to hit the most medial border of the foramen and then in lateral view you enter into the foramen. In that way, without knowing depth, you will not go too much inside the foramen, it will be much more safer. And Bone is our friend. That's why bone will help you to understand the depth and the safety that you are outside the foramen, and in lateral view you are entering into the foramen. Now we'll see the lateral view. In lateral view, I will not maintain the same obliquity what was used for the submental view, because that is not applicable in this case. In lumbar spine, we do the oblique view for the squaring, and we are maintaining the same obliquity in the lateral AP everywhere. But here, we are not following that. We have to take the image intensifier in such a way that all the structures they superimpose, mainly both the mandible, both maxilla, the slope of the clivus, then the petrous, they should superimpose. Then I will see the base of the skull perfectly, so that I can assess the depth of the needle perfectly inside the foramen ovale. So we'll see now. So when you are doing lateral, particularly in the head face procedure, keep it in your mind, KB will be less in lateral and more in AP oblique. Whereas in the whole part of the body you have seen, when you're coming to the lateral view, the exposure is needed more than in AP view, but in cervical level, the exposure is less in lateral view, more in the AP view. Now we see in the lateral picture, so before entering into the foramen ovale, we should learn the structures from inside. So here we can see the cavernous sinus on both sides of the cellator ceca. It is a venous sinus. Cavernous means so many rooms are there, small pockets are there through which internal carotid is gone. We'll see it afterwards. So this is cavernous sinus. It's connected with the basilar plexus. So these are the petrosal sinuses. Okay. So now we can see here the foramen ovale, foramen spinosum, foramen rotundum, middle cranial fossa. So if we take a section at the level of the pituitary gland, if we take a section there, then how it will look. Let's see. So we can see here the pituitary gland. So this is the body of the sphenoid, the sphenoidal sinuses. Then on the both side of the body of the sphenoid and the pituitary gland, we'll see this, the cavernous sinus. We can see the venous pockets, where the lateral wall of the cavernous sinus from top to bottom, third cranial nerve, oculomotor, fourth cranial nerve, trochlear, then the sixth cranial is going through this, accompanying with the internal carotid artery, then coming ophthalmic division of the trigeminal, and this is the V2, the maxillary division. So the lateral wall, we can see these are the nerves there, and you cannot see here the V3, the mandibular division, which is gone in this area and gone down through the foramen ovale. So here, lateral part of the cavernous sinus, we can see the temporal lobe, both side. So when you are putting the needle for V2, V3, we are keeping the needle in this area. So you have to be very, very cautious. You will puncture the dura, you may puncture the sinus. So your needle should not go too much inside. You can puncture the internal carotid. So how internal carotid is coming here, so we should see that. If you see, the internal carotid is going through the petrous part of the temporal bone and through the foramen lacerum, then it is coming at the middle cranial fossa and going through the cavernous sinus and taking a turn. It is called carotid siphon, and then after taking the turn, it is forming the circle of Wills with the posterior cerebral artery. This is the area. So this picture you have to think. So now we can see the interior of the skull. So this is the foramen ovale. This is foramen lacerum. This is the petrous part of the temporal bone, anterior slope, posterior slope. In the posterior slope, we can see the internal acoustic matrix through which 7-8 nerve goes. So this is foramen ovale. This is foramen rotundum. You can see this. It will go towards the sphenopalatine fossa, and then it will come out through the inferior orbital fissure. Now this is the sella turcica. This is the slope, the clivus, anteroclinoid process. Posterior clinoid process is broken here. So this is the other side, foramen ovale, petrous part of the temporal bone. The anterior slope, if I go medially, so this is the place which is called the Michel's cave. Here also Michel's cave. If I feel with my finger, I will come here medially and I will fall in a fossa. So that is the Michel's cave where trigeminal ganglion is residing. Here also Michel's cave. And if you see the Michel's cave, just exactly below the Michel's cave, we are getting the foramen ovale. Now you will understand what is the fact behind this clivus petrous junction and the needle trajectory. So you see here, this is the petrous, superior border of the petrous. All you have seen is the Michel's cave. Here the superior border of the petrous. This is the clivus line. So this is the junction between the clivus and petrous, where you will get the Michel's cave, which is just below the foramen ovale. So that is why when we see in the lateral view, the needle trajectory should be at the junction between the clivus and petrous. So now you see in the lateral view, you can see this is the sella turcica, clivus, this is the petrous, body of the sphenoid, sphenoidal sinus, this is the slope of the clivus, petrous, posterior clinoid process. So that is the junction, towards the junction of the clivus and petrous, where you will get the foramen ovale. See here. So that's the clivus. So in the lateral view, you should always keep the C1 in your picture. Once you keep the C1 in your picture, so you can imagine here is the foramen magnum, just anterior border of the foramen magnum. You can imagine this is the clivus, slope of the clivus, sella turcica. Okay, this is the petrous. So clivus and petrous junction. See, clivus is little up because of this posterior clinoid process. So clivus and petrous junction. Towards this, you will get the foramen ovale. Clivus and petrous junction. Okay, needle trajectories there. This is the zygomatic. Lower of the zygomatic is at the level of the foramen. In the lateral view, other procedures, the sphenopalatine ganglion block, you can find out here. We can see this teardrop. So that is the pterygopalatine fissure or pterygomaxillary fissure. This is the pterygoid plate. This is the posterior surface of the maxilla. This is the mandibular notch, condylar process, coronoid process. So actually the sphenopalatine ganglion block cannot be done in the tunnel view because this coronoid process is almost at the same level. That's why we are taking as anterior as possible in the mandibular notch and entering into the pterygopalatine fissure. So this is the opposite vas, or I used to say better you see the pterygomaxillary fissure and try to enter it. Anyway, that is the other block. So again here And so this is the trajectory towards the petrous clivus junction to go through the foramen ovale into the middle cranial fossa. See the picture here, we can see the nerve, trigeminal, it is coming towards the Michel's cave, see here, petrous clivus junction, clivus petrous junction, that is the Michel's cave. So we can see here. So from both the side, you can understand what is the importance of the lateral view and comparison between the real anatomy with the fluoroanatomy. Now, if we are watching from the top, we can see here this is a slope clivus where the foramen magnum, where you can see the brain stem, the lower part of the medulla, okay, where the spinal cord is ending and the medulla starts at this place. We can see here this is the lower part of the medulla, we can say, because we can see the last 12 cranial nerve hypoglossal. This is the internal acoustic meatus through which the 7, 8 is going. We can see this is the 6th cranial nerve. Here is the 3, 4, and this is the trigeminal. We can see here trigeminal, how it is residing on the Michel's cave. We can see this is the petrous. So this is the V1, V2, V3 on the lateral wall of the cavernous sinus. Here we can see the internal carotid is come out after taking a turn, this carotid siphon. Now it will form this circular fields. So now we can see this picture little magnified way. You can see here, this is the trigeminal ganglion, this is foramen ovale, foramen spinosum, this is foramen rotundum. You can see V2 is going there. So this will be the supraorbital fissure through which V1 and all other 3 cranial nerves are going. So when we are taking the needle inside, you have to be so cautious to plan for the V2, V1. Now if you see the dissected part here, this is the petrous part. Here is the petrous part, this is the clivus, foramen magnum, this is the pituitary gland. Here you will get the cellular turcica. So here you can see the ganglion and it is coming to the foramen. So this is the V3. The motor branch will be medial to it. So motor is always medial. I will tell you for every cranial nerve where it is having motor as well as sensory, the motor will be always medial to the sensory branch. Why it is, I will explain you. And this is V2 and this is V1. So V3, V2, V1. So is the most medial part of the foramen. If you are planning to go for V1, so you have to imagine how much you have to come inside, how much you have to come medial, how much you have to come superior. So accordingly, you will be able to get the stimulation. Then I will show you, I have taken some measurement on 6 skulls so that we can assume how much I have to go inside. So if I am planning for V1 and if I am planning to ablate the ganglion, how much I have to come inside so that I can reach to the middle of the Michel's cave. See, you can see the pons, the brainstem. The brainstem is placed here. You can imagine it. How from the pons, the sensory root and the motor root, they are coming, and this is the ganglion. It is residing here. You can compare with this picture. See here, pituitary gland, V1, V2, V3, trigeminal ganglion is here, petrous, temporal, foramen magnum, clivus. So when we take out the brain and try to see these nerves, you can see this 2 hemisphere. I have taken out half of the hemisphere, so you can see this half of the brain stem. You can compare with this. So this blue part, what I kept like cavernous sinus, we can see here, this is the foramen lacerum. Here we can't see the foramen ovale, which is there. This is the foramen rotundum. So this is the Michel's cave, petrous part. Okay, you can compare with this. Now what I was telling, that if you see how the cranial nerves are coming out from the brainstem, so it is the pons in the midbrain, 3 and 4th cranial nerves are coming. Here it cannot be seen. So from the pons, we can see where the middle cerebellar peduncle, just anterior to the middle cerebellar peduncle, we can see the thin motor root medially and thick sensory root laterally. Whereas at the pontomedullary junction, if you see, this is 6, 7 and 8. Okay, so now 7 we can see it is having also sensory and motor roots, but thick medially motor root and thin sensory root. So you can see, if you compare with this trigeminal and facial, which are very, very important role on the face, so their motor is always medial. Why motor is medial? Why sensory is always lateral? Is developmentally, if you see the section of the spinal cord, then we'll see the anterior horn and posterior horn. In the anterior horn, the motor roots are coming out, and the posterior horn, the central process of the sensory cell bodies which are residing in the ganglion. So there the relation of the sensory root and the motor roots are anteroposterior. When this spinal cord is going up and forming the brainstem, it is opening like a book, okay, where posteriorly the cerebellum, anteriorly the brainstem, in between the fourth ventricle. So as it is opening like a book, the relation between the motor and the sensory roots, they come into medial lateral. That's why always motor root is medially, sensory root laterally. Facial motor, thick motor root medially, thin sensory root laterally. See here, this part is for the motor, this part for the sensory. They are related medially laterally. That's why motor and the sensory roots are related in the same way. Now we can see the trigeminal nerve. You can see the trigeminal nucleus is there in the whole brain stem. This is mesencephalic nucleus because it is in the mesencephalon. There is a midbrain. This is the chief sensory nucleus or the principal sensory nucleus that is there in the pons, and we can see this long hair. So that's the spinal nucleus. See, spinal tract and the spinal nucleus. And red, this is the motor nucleus. So this motor and the chief sensory, they are residing at the pons. We can see how they are coming out through the pons, and this ganglion will be residing at the Meckel's cave. Now I will come to the point. So whether any relation between this trigeminal ganglion and the dorsal root ganglion. So if you see here, what is the relation between trigeminal ganglion and the dorsal root ganglion? They are actually same. So if you cut the body at the C1 level, the whole lower part, their sensory is coming through the dorsal root ganglion. The sensory cell body is residing at the dorsal root ganglion. And at the head face part, the cell bodies of the sensory neuron is residing in the trigeminal ganglion. So that's why they are actually same. Trigeminal and the dorsal root ganglion, there is no difference. The rule of the neuroanatomy is sensory cell bodies cannot be there inside the spinal cord of the brain. That's why trigeminal ganglion is same like dorsal root ganglion. It is a somatic ganglion which is inside the cranial cavity but outside the brain. Okay, so whatever the cell bodies are there, they are all pseudo-unipolar. You can see the different types of neurons. The unipolar neuron, bipolar neuron. Unipolar is not shown here because in the embryonic period unipolar neurons are there. So this is the bipolar neuron, which is mainly we are getting in the olfactory, in the ear, but motor neurons are mainly the multipolar neurons, where the sensory neurons, what you are getting in this dorsal root ganglion or in the trigeminal ganglion, they are the pseudo-unipolar neuron. They are having one central process, one peripheral process. Okay, central process is attached to the spinal cord and peripheral process is attached to the periphery. So if you see here, we can see this is the trigeminal ganglion. We can see the cell bodies are there, same like your dorsal root ganglion. Okay, the central process, peripheral process. Here also central process, peripheral process. Only exception is the mesencephalic nucleus. The mesencephalic nucleus, it is there in the mesencephalon, that is the midbrain, because that is carrying the proprioceptive function. Just for example, we are continuously chewing, having food, but never ever we bite the tongue. So how our mandible knows that I am not going to bite my tongue, but I can bite all the food, whatever I like. Even if I'm sleeping, I will never ever do that. So why? That is your proprioceptive sense. There is a sense of own. You cannot do any wrong for yourself. So that is the proprioceptive fiber. So that nucleus is residing at the mesencephalon. It should be there here, but as it is sensory, but that is the exception. The mesencephalic nucleus, it is residing in the brain, though it is a sensory nucleus. You can see here it is the central process attached to the motor nucleus, and peripheral process it is attached to the muscles of mastication. So in that way it is protecting ourselves. So mesencephalic nucleus. If you want to know more precisely how all these three V1, V2, V3 pseudo-unipolar neurons are connected in the spinal part of this trigeminal nucleus. So the V3 is connected to the upper part, that is pars rostralis. V2 is connected to the middle part, pars intrapolaris, and V1 is connected to the lower part, so which is pars caudalis. So anyway, it is not much important for our technical part, but for knowing little more anatomy, we can now understand how this dorsal root ganglion, which is actually carrying the sensation to the thalamus at the VPL, ventroposterolateral part, whereas whole head first part, they are reaching to the VPM through the trigeminal nucleus. Another important point for trigeminal nerve is it is also connected with this parasympathetic ganglions. In cervical parasympathetic ganglions, there are ciliary ganglion, otic ganglion, pterygopatal ganglion, and submandibular ganglion, where preganglionic fibers are coming from different cranial nerves, like ciliary ganglion coming through third cranial nerve from Edinger-Whipple nucleus, then the preganglionic fibers of sphenopalatine ganglion coming from seventh nerve, preganglionic fibers of otic ganglion coming from ninth nerve, preganglionic fibers of submandibular ganglion, again it is coming from the seventh nerve. But the postganglionic fibers for every parasympathetic ganglions are the branches of trigeminal nerve. Okay, for ciliary, the short ciliary nerves. For pterygopalatine, branches of maxillary nerve. For otic ganglion and submandibular ganglion, branches of mandibular nerves. Okay. So we have to realize how the trigeminal nerve is so important in our head face. It is having different types of fibers, whether it is sensory fibers, whether it is motor fibers, whether it is postganglionic parasympathetic fibers, even it is having proprioceptive fibers. We will see now how the trigeminal nerve is connected with the other cranial nerves. You can see here, this is a picture of the brain stem, where this midbrain, there is the pons, there is the medulla. So in the midbrain, at the level of the superior colliculus, the third cranial nerve is coming out, where the preganglionic fibers of the ciliary ganglion, which is situated here, which is coming from the Edinger-Whipple nucleus. Okay, you can see number 1, here it is Edinger-Whipple nucleus, coming through the oculomotor nerve. Then we can see here the number 9 it is showing. So this is superior salivary nucleus. Actually from there the 7th nerve is coming. See, number 10 is facial nerve. And now from facial nerve, the preganglionic fiber of the sphenopalatine ganglion, you can see here number 11, there is the greater petrosal nerve, and preganglionic fibers of the submandibular ganglion. And this is the 9th cranial nerve, is glossopharyngeal, where the preganglionic fibers are coming through the glossopharyngeal nerve for otic ganglion, and from there, otic ganglion, from sphenopalatine ganglion, from ciliary ganglion, from submandibular ganglion, everywhere the postganglionic fibers are the branches of trigeminal nerve. So this is very, very important to know this neuroanatomy, because many times we are getting different problems. So to correlate with different nerves, how the trigeminal nerve is connected with the 7, 3, 9 through these parasympathetic ganglions, this will help you to correlate many problems. Now I will show you the needle positioning when you are entering through the foramen ovale and trying to place the needle for V1, for V2, and even at the trigeminal ganglion. Now we will see what will be the radiological picture when we put the needle through the foramen ovale. So I have kept the skull under the fluoroscope. We can see the submental view, already we have seen in our earlier discussion. Now I have kept it oblique to see the foramen ovale. You can see the foramen ovale here. Now what I did, I made a model with the thread. So this is the trigeminal ganglion. This is the trigeminal nerve which is coming here and forming the ganglion at the Michel's cave. These are the three branches. This is foramen lacerum, foramen ovale, foramen spinosum. V2 is going through the foramen rotundum and V1 is going to the superior orbital fissure. They're all placed the lateral part of the cavernous sinus. This blue part, I made it like a cavernous sinus. If we see from the front, we can see how the V1 is coming out through the superorbital fissure, V2 is coming through the infraorbital fissure. Okay. Now I will see the lateral view where we'll try to superimpose all the structures on the both sides, and I have kept the needle. You can see the needle is kept there just outside the foramen, just outside the foramen. Okay. And what we will see in the lateral view. So needle is put at the just outside the foramen, just at the foramen. Okay, you have not gone inside. Then what you will see in the lateral view? You will see in the lateral view, the needle is at the level of the zygomatic. So I can see this is the zygomatic and here is the foramen ovale. So if you see, the outer border of the foramen ovale is just at the level of zygomatic. So if in fluoroscopic view, if I see the lower border of the zygomatic, my needle is just at the level of the foramen, just about to enter at the foramen. Okay, see the hair. See, you can see this is the foramen. So this is the level of the zygomatic. So after coming to the outer part of the foramen, you should see the lateral view, making everything almost superimpose. You can see this is sella turcica, this is the clivus, and this is petrous. So needle is targeted towards the clivus petrous junction. So your needle trajectory is perfect. If many times you are not able to find out the foramen, this is the external acoustic meatus. If the needle is not properly placed, as we are watching the pneumatic bone, many times we are puzzled to see the foramen ovale. So then if you see the lateral view, if it is not in this trajectory, try to correct the trajectory and go back into the oblique view, submental view, and you will definitely be able to see the foramen. Then you correct it and you touch the outer border of the foramen as per V1, V2, V3, and again you come into lateral and enter inside the foramen as per the lateral view. Okay, so you can imagine here, so this is the lateral part of the sella turcica where the cavernous sinus is there and all the lateral structures, and through the cavernous sinus we have already seen the internal carotid is going. Now needle is taken almost up to the Michel's cave. So here you can see towards the clivus and petrous junction, but needle has come quite up here, almost at the upper border of the petrous part. But it is not on this side, so it is towards the clivus and petrous junction. So if you are coming here, then you are touching the ganglion. Now if I am taking the needle more medially, actually it's not medially, little anteromedially, to touch the V2 or V1 on the lateral wall of the cavernous sinus, then you will see how it looks like in the lateral view. See, now this is clivus, this is petrous. The needle is not directed towards the clivus petrous, it has gone little anterior. Actually it is anteromedial, but in lateral view you will feel the needle has gone little anterior and it is almost coming to the base of the cella turcica, where you will touch to, this will be V2 or V1, because above we will get this another 3 nerves. So this is very, very important to see the lateral view. If we're thinking for V1, V2, in submental oblique view, you have to take the needle more medially, and then in lateral view, you take the needle quite up, almost up to the base of the cella turcica, because there you will get the V1 and in this level you get the V2. But you can see the trajectory is not coming towards the clivus petrous junction. Okay, so that's a very important thing. You can see here I have kept the 2 pictures where this is towards the clivus and petrous junction, but this is towards the V1, V2, because this area you will get the cavernous sinus. It is not directed towards the clivus petrous. So in this way we can finalize the needle positioning for V3 and V1, V2, and ultimately your needle position will be finalized with your motor and sensory stimulation. Now I will show you some measurements related to the foramen ovale when you are coming inside to reach your target. The measurements are taken by our MSc students, Ms. Suvarna. I am highly thankful to her. Let's see the measurements. Here she is taking the measurements of the foramen ovale, transverse diameter and the longitudinal diameter. Then she is taking the measurements of the taking the measurement of the distance. Then she is taking the measurement of the distance from the medial border of the foramen ovale to the middle or in the upper part of the cella turcica when we are planning to place the needle for V1 and V2. Then she is taking the measurement of the distance from the posterior border of the foramen ovale to the middle of the Meckel's cave. If you are planning for ablating the ganglion, this may help you. So we can see here the measurement of the foramen ovale, which is not even a centimeter. You can see the longitudinal diameter is not even a centimeter. And again we are dividing this into 3 parts: medial, middle and lateral for V1, V2 and V3. So you have to be so precise to put the needle. And why I'm telling, you can see the transverse diameter also not more than 3 to 4 millimeter. That's why after focusing the foramen ovale, again I am doing that cephalocaudal to get the maximum ovality of the foramen ovale, so that I can get the maximum size of the foramen ovale. Now coming to the second measurement, which is the distance between the medial border of the foramen ovale to the middle of the cavernous sinus. So that is for V2 or V1, you can say. So it is not more than 10.5 to 11 millimeter. So when you are putting the needle in between the cavernous sinus and the temporal lobe, you have to be very, very cautious. You should not take the needle too much inside. It may pierce the cavernous sinus, it may injure the internal carotid artery. So this measurement may help you when you're taking the needle most medially and anteromedially. And now when you are planning for ablating the ganglion, so then you are taking the needle at the same direction, the petrous clivus junction, but you are taking the needle quite up to reach the middle of the Meckel's cave. It is almost 12.7 to 13 millimeter. So this measurements may help you to place the needle inside the skull for V1, V2, V3. And you have to know all these structures before doing all these procedures, because these are very, very complicated procedure. You may injure other structures when you are putting the needle inside.